what I'm gonna observe, just gonna make that, put that there. We're gonna, no, you're fine. We're gonna take up our observations. So in her resting position, she sits a little bit into a posterior pelvic tilt. She has forward head, a little bit of rounded shoulders. It's okay, do your thing, you're good. Because we don't know if this has anything to do with her injury. If she came in with low back pain, okay, that's putting a lot of stress on the posterior ligaments. If she's complaining of neck pain along this lower C5, C6 region, it makes sense because her head's poked out. All I'm taking in as I observe it, I can hypothesize that she may have some decreased strength or stability at her deep cervical neck flexors, possibly poor core or scapular strength based off of rounded shoulders. She may be tight up front. That's all I'm taking in. She didn't give me any history. These are just what could happen based off of this observation. So that's my observation for posture. Palpation. Can I put my hands on you?
Yes.
Okay. So when we do palpation, now I just want you to sit up nice and tall for me and just look straight. And all we're gonna do is, if I touch anything that hurts, let me know if you have any pain, okay? I have 28 people here that can also see your face. No pressure. So I am just looking at the vertebrae, seeing if everything is in line, if there's any muscle asymmetry. I'm palpating down, levator towards the superior angle, going along the side of the neck and transverse processes down, looking at scalenes, looking at overall upper traps, seeing if anything's there, looking at scaps compared to her spine. Ooh, I'm not that quick, sorry. And so seeing how far away from the spine the scaps are sitting, which they're abducted. I'm looking at the angle of her scaps, and she is downwardly rotated. Is that normal? No, should be in slight upward rotation. So now I'm looking into levator scap or rhomboids. So it can't be rhomboids in my head because she's abducted, where it can be levator scap because she's downwardly rotated. So now if she complains of mid-neck pain, anything along her superior angle on either side,
Those
that's
are tender.
that's something I would be interested about.
The elevator's tight, or something is tight.
Tight, short, all those things, because she's sitting in a downwardly rotated position, but she's still abducted. So when I go for that, yes, now I'm looking for asymmetrical tenderness along the muscle. But that's all I get that is because of the scapular alignment. That's without even worrying about does it hurt, does it not hurt. You can get into the deepness of it and look for an asymmetry. She has some resting tension in it. Any differences between right and left?
The left is more tender.
Okay, are you a righty or a lefty?
Righty.
Okay. Any pain here?
No.
Okay, any pain over here?
Oh.
Okay, any pain here? Good, any pain here? So am I not too worried about neck pain contributed by levator scap at the moment? At least there's no reactive muscle. It can affect her neck and it can affect her shoulder. It is not currently muscularly driven neck pain at this point because the muscle feels normal. It's a little stiff, but it's not creating any asymmetrical pressures. So that's palpation. Her spine felt like it was in alignment when I looked at transverse processes. This is statically, not dynamically. We can go along clavicle, back. We didn't look into first rib, but basically your first rib, if you drop right behind your clavicle and right off the cliff of your upper trap, you'll feel a hard thing. That's your first rib. You could follow that in towards your lower cervical spine where it attaches to. Muscle bulk, posture. I think that's it. You can do palpation, you could do pulse. At this point with her sitting, I'm not gonna say, hey, lay down and sit back up for palpation of the abdomen, nor did I take a history, just fun fact. Take pulses. How you feeling?
Good.
Good. Long day?
Yeah.
Okay. Good. So that's what I'm looking at so far. Range of motion, selective tissue tension test. So for range of motion, if anything hurts, please let me know. If you don't say anything, I assume everything does not hurt.
Okay.
Don't be shy, okay?
All right.
Okay. I'm gonna have you look down towards your chest. Good. Overpressure.
That hurts.
Okay, where?
Like here.
So upper left side region?
Yeah.
Okay. Look up, sorry, stay down there, come up just a little bit. Don't let me push you any further. Good. Any pain?
No.
Okay, look up towards the ceiling. Good. Okay, come out of that. Good, stay there. Don't let me push you. Good. Bring your left ear to your left shoulder. Good, come back up straight again. Good. Do it again. Okay. Nope, stay there. Good. And push to your right.
It's cracked.
Cracked. Oh no. Are you okay?
Yeah.
Okay. Bring your right ear to your right shoulder. A little stiff on your left, but otherwise. So I'm just taking a note
Yeah, that
of
hurts.
this muscle right here. Come back. So right now I'm worried about your scalene. I'm saying this to you. You don't be scared. I would never say that to a patient. Just so that you guys can know what I'm looking at. So bring your head to your right again. I'm looking at this pole right here. So that to me is scalene. I'm also worried about nerves here as the brachial plexus tractioning. Okay, sorry, I don't even remember what I did. Okay, this,
That
good.
hurts.
That hurts where?
In that same spot from
Up
forward.
here or down here?
It's like here.
Okay, and then come up
Like
a little
close.
bit. Good, hold.
No.
Okay. And then rotate to your left. Good, any pain?
No.
Good. Come out. Don't let me turn you any further. Good. Turn to your right. Good. Good. Don't let me turn you any further. Good. Now I'm gonna have you do is bring your chin in towards your neck. Good. Any problems with that?
No.
Okay. Look up towards that tile right up there. Any problems with that?
No.
Good. Bring your head back to a neutral position. Good. I'm going to place my hand underneath your chin. I'm going to place my hand on top of your head. Don't let me pull you. Good. Resist, resist, resist. You're doing good. Doing good. And relax. Good. Stay right there. Don't let me move you, okay?
Okay.
Hold. Good. You let me know if I get any compensations. For some reason, I just feel like you're using your SCM, but I can't see it. Good.
No, yeah, it's popping. Yeah.
Good. Where were you guys at? You're supposed to tell me these things. Thanks. Jeez, I'm not a
For
magician.
extension, for sure it was. There's just like
Hold, 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 hold.
Try again.
Okay, so she uses her SCM to compensate. So I'm now concerned about deep cervical neck flexors because of this and because she can't handle rotation without SCM. And we said before, based off of observation, what was one thing that could have possibly been a factor? Forward head creating lengthened muscle. If your forward head posture is like this, is there any part of the back of your neck that can be compressed? Where? Upper cervical, which is one area she pointed at pain, and another would be mid to lower, another area she had pain. I'm just putting these on a checklist going, okay, that at least makes sense. Not thinking tumor, thinking mechanical neck symptoms. Good. So that would be range of motion, STTT, and that would have been gross strength. So far, so good?
yeah.
Face me.